day everyone, my name is Dr. Barclay Karnatki and I'm currently pursuing my internship after completion of my MBBS from Jawaharlal Nehru Medical College, Belagavi. Welcome back to my YouTube channel. Last time, we spoke about cell injury and various adaptations to this cell injury. Today we will be talking about amyloidosis under a few basic headings, namely what is amyloidosis, the properties of amyloidosis, the types, the clinical features, diagnosis, and a few recent advances regarding this disorder. So now, without further ado, we'll start with what exactly is this disorder, amyloidosis. So now amyloidosis is nothing but an abnormal aggregation of extracellular fibrillar proteins leading to a specific set, a very non-specific set actually, of symptoms, right? So now usually what happens is proteins at the end of their lifespan are degraded intracellularly either by proteosomes or extracellularly by macrophages. But if there is a failure of these regulatory mechanisms, right, there will be an aggregation of protein or fibrillar protein in this case outside the cell, leading to a set of symptoms. So that essentially is what amyloidosis is. Now there are a few properties one would like to look at of these amyloid proteins. So firstly, these amyloid proteins, as I mentioned earlier, 95% of them are fibrillar in nature. The remaining 5% belong to a P component of a specific glycoprotein, right? And there is not one specific protein that aggregates extracellularly. In fact, there are over 20 proteins that can aggregate extracellularly. On electron microscopy, these proteins have a diameter of either 7.5 to 10 nanometers, and on X-ray crystallography, they show us a beta-pleated structure. Now we will look at the forms or types of amyloidosis. The first form, namely being the AL type, it is made up of complete immunoglobulin chains, right? Mainly of lambda, but sometimes kappa chains can be involved too. Now plasma cells physiologically produce antibodies. So if there is a problem in the production of antibodies, right, such as a plasma cell dyscrasia or multiple myeloma or Waldenstrom's disease, there will be an overproduction of these antibodies, leading to an aggregation of these light chains outside the cell. Now, there's not much we can do for treatment in case of plasma cell dyscrasias, except for perhaps a stem cell transplantation or a few monoclonal antibodies, which we will talk about later. Now, the next type we will talk about is the AA type. This is an amyloid fibril which is produced by the liver, right? So serum amyloid protein, SAA, is produced by the liver. And this type of amyloidosis is seen in chronic inflammatory conditions such as rheumatic arthritis, ankylosing spondylitis, and in these conditions there is an increase in the serum amyloid protein produced by the liver, and in turn more deposition of amyloid. The third type we will look at is beta-amyloid protein. Now this is usually seen in Alzheimer's at the cerebral core. Other than these main three forms, there are two not so common forms I would also like to talk about. The first protein being transthyretin. Now physiologically, transthyretin transports retinol and thyroxine. However, in a group of disorders called familial amyloid polyneuropathies, this transthyretin itself can get deposited extracellularly, leading to a set of symptoms. The next one I would like to talk about is beta-2 microglobulin. This is a common protein found in your major histocomplex 1. However, in cases of renal dialysis, where this protein is not filtered out, there can be clumping and aggregation leading to nephrotic syndrome or other serious renal implications. Now, pathogenesis, as we spoke about this earlier, that usually proteins at the end of their lifespan are degraded intracellularly either by proteosomes or extracellularly by macrophages. Now, if this fails to occur, these proteins won't get degraded, they will clump out extracellularly and lead to the set of symptoms and this disorder called amyloidosis. Now, amyloidosis can either be systemic or it can be localized to a certain organ, right? So now when we look at the clinical features of amyloidosis, at first it is usually very non-specific. So weakness, raccoon eyes, lightheadedness, weight loss in the early stages. In the later stages, once the organs are involved, it could lead to renal involvement, leading to nephrotic syndrome and proteinuria in the earlier stages. Cardiac involvement, it may present as insidious congestive failure. A restrictive pattern of cardiomyopathy may be seen, and in serious complications of cardiac involvement could be conduction disturbances and arrhythmias. We will also look at GI amyloidosis as a local involvement. However, the set of symptoms there are very non-specific. Could be diarrhea, could be vomiting, could be inability to absorb food. There could also be amyloidosis of the tongue, which could hamper speech or taste. Now, diagnosis of amyloidosis. We will be able to diagnose amyloidosis only once this protein is actually demonstrated or once it is visible, right? So there is a stain called the Congo red stain, which is used for amyloidosis. And this Congo red stain, once it stains this amyloid protein, shows us an apple green bifringence. Now we may be wondering, where do we demonstrate this protein from? So in a person showing non-specific symptoms, the abdominal fat pad is usually biopsied. Now we will look at the last bit of it, which are the recent advances in the treatment of amyloidosis. As discussed earlier, the AL type of amyloidosis is treated using stem cell transplantation. However, recently, there has been a drug called daratumumab that is a monoclonal antibody directed against CD38, a cell surface specific antigen on myeloma cells, and it has recently been used and tested with a great amount of efficacy regarding the treatment of AL amyloidosis. So, thank you so much for all of your support, and please subscribe, like, share, and I will see you on the next video. Thank you and have a great day.